Hello, I'm Frances Steed Sellers, a senior writer here at the Washington Post, and I am delighted to be joined this morning by Cynthia Fisher, who is the founder of patientrightsadvocates.org, sorry, tripped over that, and Mark Miller, who is the Executive Vice President of Healthcare at Arnold Ventures. And a very warm welcome to you both.
Thank you, Frances.
So Mark, I'd like to start with you and talk about the difference a little bit between regulations and reality. We had the ACA in 2010, and we've had further federal regulations in 2021, I think. How do those work, and what's the actual reality for a patient when it comes to hospital pricing transparency when they enter the emergency room and end up in the hospital?
Well, I don't think there is any pricing transparency. Patients can ask questions, but I think often the providers and insurers either can't give them a complete answer or don't give them an answer if they're actually aware of it. Our agenda is about affordability, and we're focused on the affordability for the three actors that pay for all health care in the end. So in the commercial sector, your employers and your households pay premiums and co-payments, and of course on the public side, it's the taxpayer. We think transparency is absolutely a critical first step in solving that problem, but you also have to go beyond transparency. The senator just noted the level of consolidation in hospitals. Now 90% of hospital markets are highly consolidated. They become price setters in their communities, and our prices are routinely 250, 300% of Medicare rates. So the patient doesn't know the price and often can't afford it once they encounter it, either through their co-payments and, of course, all that gets built into their premiums.
So Cynthia, you've studied all of these things, and again, tell me a little bit more about what the ACA and the regulations of 2021 were trying to achieve, and how hospitals can flaunt this, according to what Mark says.
Well, since 2021, the Trump administration put into play from the Obama administration, the Affordable Care Act, a law that was sitting on the shelf, the part of the law that we have the right to know all prices.
Right.
And that is everywhere in healthcare, from the hospitals and the insurance companies and system-wide. So they put it into rule of law, and then Biden increased the fines when hospitals in the first 6 months were flouting the law and not posting all of their prices online. So Biden increased it to over $2 million per hospital. So we have 3 presidents, bipartisan support to give us all the right to know all prices. And price transparency is so truly transformative because it shifts the power to the patient and to employers and unions and all of us, even taxpayers and people on government plans, to be well informed in advance of care of the true prices and costs, and to be able to make choices on where to get their care and have financial certainty to get the best quality of care they need at prices they know they can afford.
So a quick follow-up for you. We have these bipartisan, presidents from 2 parties. What does this mean for Congress now? Is there bipartisan energy behind legislation to actually take us a step further and enforce?
Absolutely. This is an over 90% issue across the board, bipartisan support from Congress. And in fact, the House currently has a bill of lower cost and through Price Transparency Act that is sitting ready for votes to the floor. And in the Senate, there's a lot of activity, bipartisan, from both Bernie Sanders and the Republican senators alike, to see price transparency implemented, because everyone has a story. Everyone has a story of being overcharged or have a family member that has experienced significant medical debt. We have 100 million people in this country with medical debt. And the problem is that without getting prices, people don't have the ability to have remedy and recourse. And price transparency, even with only 36% of the hospitals in our last report in July, of the 6,000 hospitals, 36% are fully complying with the law. Now there's enough data out there that patients are able to look at their medical bills and see if they were appropriately charged. And let me tell you, the power of that. We see patients like Mason Kochel from Grand Junction, Colorado, who was given an EpiPen at the end of a hospital visit, and he was charged $16,000 for that EpiPen, $16,500. And the insurance negotiated it down to $4,900. And he knew surely he had to be overcharged because he's only paid $70 for an EpiPen with a prescription in the past. How does he fight it? Well, he went to the hospital pricing file and found his insurance plan. The negotiated rate was $300. Still a crazy amount for an EpiPen.
And a very educated person who could follow through on all these steps, right?
Exactly.
I mean, that's
exactly
one of the inequities here. But
If
Mark,
I could just comment on the House bill for a second. What the House bill does is it codifies the regulatory changes on the reporting of the prices. A second piece, and we support that completely, a second piece of transparency that I would say that the Congress needs to take up is also transparency into ownership. Who owns the hospital, who owns the physician office, who owns the nursing facility, because this consolidated position that they have allows them to set prices throughout. That bill also goes on and embraces a policy that's referred to as site-neutral policy. What that is to address is when a hospital purchases a physician practices, they redefine the hospital or the physician practice as a hospital, and then on the commercial side, they add a facility fee, and on the Medicare side, they bill it through a higher hospital rate. Let me just finish. And what this would do would say that for routine services in a physician offices, you cannot raise it to the hospital prices. So they're looking at transparency, but they're also taking action to try and make the price more affordable.
So I have a very practical question. Here I am, I walk into the emergency room. I actually don't probably know what I need. Something has happened to me. How can I go about price shopping as a consumer?
And this is why, with all respect, we absolutely embrace transparency. It is a first step, in my opinion. It is necessary, but it's not sufficient. I don't think the patient often is in a position that they can negotiate. If you're unconscious on a gurney, you're not negotiating. And I would go further. Employers that I talk to will say, I can't negotiate with a hospital system that owns all the beds in my mid-size MSA. I cannot negotiate them if they own all the physician offices. So knowing the price is a first step. I think it brings the press, policy makers, and patients to the table. But I think there are steps that have to be taken beyond that, like the site-neutral policy.
Cynthia, is the U.S. a total outlier in this?
Well, Francis, you did an outstanding job the other week in writing about the crisis that we have in our country right now. You wrote about the degradation of our life expectancy, that our life expectancy has declined drastically. We pay over 2 times any other developed country for healthcare, and yet we are dying 4 years younger than the average developed country in the world. So when we compare the statistics, we're dying 8 years younger than someone living in Japan or Singapore, as your report.
Or Portugal, where I wrote about.
Portugal, as your report mentioned. And yet we're being charged over 2 times more. So there is a pricing problem, and big part of that problem is as long as hospitals and insurance companies keep prices in the dark, they can charge whatever they want. And the overcharging is rampant. And when we see prices now, just from the beginnings of these rules that allow us to see all hospital prices, and also the insurance companies having to post all of the prices for each employer by every single provider. So now we have system-wide healthcare price transparency. Don't think the industry hasn't made it difficult to see these prices. But now that the curtain has been pulled back, we're seeing wide price variation. So for instance, in many hospitals on the same day, you can see that childbirth can be $6,000, the same codes, the same obstetrician team, and another woman may pay over $60,000, 10 times more, by the same coding, non-complicated C-section in the same hospital, same team. That's outrageous. We're seeing that for drug prices. Rituxan, for instance, in one hospital, one injection, over $9,000 for one employer's plan, and another employer's paying a little over $800.
Cynthia, one more question for you again. If I go to the supermarket and choose my cereal, I have a sense of which one is more expensive right in front of me, and I also have a sense probably of which one I've tasted at somebody else's house and I might want to pay a little bit more for. Choice is very hard, right, in medicine, because I'm not sure even though I cover health, I'm not well equipped to make choices about my own healthcare. How does this market principle, how should it work in American healthcare?
Where it is already working is the employers that are managing healthcare by getting access to the prices and the numbers, that are creating and designing plans for their members to be able to save their money substantially. And what are they doing with those savings? Coming together as a collective by choosing to get surgeries, for instance, at the Surgical Center of Oklahoma, where the prices are locked in at $19,000 for a knee replacement. That employer is saving over $80,000 where they may get a knee replacement at an opaque hospital. And so instead, they're adding to the wages and adding to bonuses for those employees. I'll give you an example. SEIU 32BJ, out of New York, New Jersey, 200,000 covered lives. They looked at their data on the prices, and they saw that New York Presbyterian, great hospital, but was charging way over the other hospitals. So they decided, after negotiating that they didn't get the fair price they wanted, that they would take them out of that plan. And within 1 year, they saved $33 million. 3 years running, they ended up giving the biggest bonus in the history to 200,000 people, $3,000, plus increasing wages the most ever. That's a huge win, and that's how it's working.
So, Mark, Cynthia described very accurately this huge change in pricing. Can you talk a little bit more about the drivers behind that difference in pricing and what some of the solutions you believe might be to?
Yeah, so again, I agree with that, and I know the organization well that you're referring to, but that's very much the exception at this point. Most employers feel that they don't have the leverage, and I think there's two issues. You've implicated the second one. The first one is consolidation. If you know the prices, but I own the market, then all you know at that point is that you're being overcharged. And then you have to do something. You either have to take collective action, and you have enough market power that you can say to the hospital, no, I'm not going to pay this price. But employers are often not in that position. Go to the patient, you've put your finger on the other issue. Most patients don't really have the knowledge to pursue their entire healthcare experience through their own knowledge. They have to do what the physician says, and if the physician is owned by the hospital, referrals and advice may be influenced in that way, and the prices, as I've tried to point out, would be higher. So the driver in this, the key from my point of view, is the lack of transparency, the level of consolidation, and that an individual patient will never have the market power as one patient or the knowledge to negotiate fully on their own behalf. So the deck of policy I would go through is transparency, prices, as well as ownership, as I said. As Senator Cassidy said, higher review of like mergers and acquisition, FTC, also at the state level. There are contracting practices the hospitals engage in, gag clauses, most favored nation, that type of thing. And then I would move to things like the site-neutral legislation in the House bill. That piece of legislation is very small step. If they took a full step in Medicare, they would save $150 billion over 10 years. Wow. If they did it on the commercial side, it's more on the magnitude of $300 or $400 billion if they did it on the commercial side. But consolidation and lack of transparency, those are the drivers.
Cynthia, tell me a little bit more about consolidation. I did a story out of Connecticut some time ago, and I remember a small hospital a very important hospital for its little community was being bought by another big hospital. It was described to me by some people as economies of scale. Because of the bigger organization, prices would come down. Others said exactly the opposite, that lack of market competition would drive prices up. What's your belief about what is happening with consolidation?
Well, I think that's why we need the prices, because
Right.
if we see the prices everywhere, then we actually benefit from competition. And I disagree with Mark, because I do believe consumers can have a choice. And let's take the prices of an MRI, for instance. So in a consolidated market, you may have much higher prices for MRIs. In fact, I would quote that in my husband's health insurance plan, his MRI price at Mass General is $7,400. And he needed 2 MRIs. So I would like to say you can't teach an old dog a new trick. So I, of course, pressured him to shop. And on a trip to Florida, he was proudly able to use a firm called Green Imaging that uses excess capacity at standalone imaging centers, and for $400 got his MRI. And then, knowing he wanted to prove me even more, the next MRI he received, he got it scheduled at the time he wanted at Jupiter Hospital for $250. And it's a quality MRI, same level of quality. But now, what is his company doing? They're looking at prices of MRIs, steering everybody, creating a new plan design that lowers the cost of MRIs for everyone in the company. And what I'd like to show is that this is working. And it's not only working in the private sector with employers, like Harris Rosen in Orlando, Florida. 6,000 members, he owns Rosen Hotels. And it was reported a couple weeks ago that the average employer plan is paying $24,000 a year for a family of 4, just for health care. Think about that. For many of us who are old, like myself, that's far higher than our starting wage.
Right.
He is able to do it for under $10,000 for all 6,000 employees because he got the numbers. He got not only the prices from the hospitals, but he also get all the claims receipts, the receipts of payment, and manages it by the costs, and made direct contracting, cut out a lot of the middle players, and did direct contracting with the hospitals in the area. Well, Osceola School District is in Orlando, and they were in a $12 million deficit in their health plan, and they're the 8th poorest school district in Florida. They asked the Rosen Hotels to show them how they could save money. Within 3 years, doing the same as they have saved $41 million. And now, 5 school districts in Florida are looking to partner and do the same as Osceola. So not only at the private level, but at the school district level, this is meaning more teachers can be hired, a better teacher ratio, and it's a huge win for these employers.
Okay, talking about wins, one last question I want to ask Mark about. We've got very little time. Solutions. What do you think needs to happen?
I'm sorry, I missed it.
Solutions. What do you think needs to happen? We have very little time left, but tell me what you think.
Yeah, well, one thing before I say that is that I do think and I'm sorry, there's a disagreement, but there is.
That's fine,
I mean,
but it
I
needs to be
think there are
quick.
shoppable services, but I think a lot of the healthcare spend is driven by things that are not very shoppable. So I hope that you're right, and I see some of that change, but I don't see it coming quickly. The deck, once again, transparency, greater mergers and acquisition oversight. Anti-competitive contracting should be banned. This is like the Sutter court case. And then the stopping practices like the site neutral policy. You shouldn't be able to purchase a physician practice and then double the price overnight for the same physician, same services. That just should not be allowed.
I love hearing different points of view. Thank you both very much for joining us today. Mark Miller, Cynthia Fincher. Thank you.
Thank you, Francis. Thank you.